Yeah, that's great, Pallavi. Are you going to share my slides? Thanks. So welcome everybody to this afternoon's event, which is being held under the auspices of the National Cross Applied Research Collaboration, Applied Health Informatics collaboration. We last met in November last year, I think, and at that time, I think we'd hoped that this meeting in Liverpool would have been able to be face to face. Unfortunately, that wasn't the case. But it's great to see so many people and to hear so many Liverpool accents. I spent 9 of the happiest years of my life between 1981 and 1990 in Liverpool. I'd like to have been back today, but hopefully I'll get back soon. Next slide, Pallavi. So I'm John McLeod, by the way. I'm based in Art West in Bristol, although as you can probably tell, I'm not from Bristol. And Art West have got responsibility for leadership of this theme. And this theme has, well, 3 substantive working groups and a cross-cutting patient, public and involvement and engagement theme, and the presentations this afternoon are part of the observational research working group, and basically they're all concerned with using data better to improve health. Next slide, Pallavi. So particularly what we are going to hear about this afternoon are about different aspects of the Combined Intelligence for Population Health programme, which is related to the Cheshire and Merseyside integrated care system. You're going to hear a series of presentations related to different parts of the programme, and you're also later on this afternoon going to hear about work beyond North West Coast and Cheshire and Merseyside. We're going to have opportunities for discussion in breakout rooms, and that's later on this afternoon, and the discussion in those breakout rooms will be around the question of how to sustain successful data linkage across institutional silos. And don't worry about getting into the breakout rooms, Debbie's going to sort that out for you, and then we'll finish up with some feedback from the groups and some general discussion. Next slide, Pallavi. Yes, so just some, the usual ground rules for these Zoom-based events. When you're not speaking, keep yourself on mute so that we can minimize distractions. When you're speaking, try and avoid jargon and acronyms that some people may not understand. And if there are things that people don't understand, please post questions in the chat, and people will explain any specialized terms that they've used. If you're asking a question, could you identify yourself when you speak, and when you're not either speaking or asking a question, could you keep yourself on mute? Can we have the next slide, Pallavi? So you can see that we've got a packed programme this afternoon. We're about to start on session 1. I think we're almost on time. So the plan is that session 1 will go on till just before 2 o'clock, and then we'll have a bit of a discussion, and then we'll have a 10-minute comfort break just after 2 o'clock, and then session 2 will start at 2:15 or thereabouts, depending how we're keeping to time. And the general discussion in the breakout rooms will start at 3:05, and we're hoping to finish round about 4 o'clock. So, I mean, thanks very much. Without further delay, I'll hand over to Sarah. Thanks.
Thanks very much, John. So yes, thanks very much for coming today. I'm pleased that we've got quite a diverse audience here, including people, I think, from the NHS Innovation Agency. We've got a few of our public advisors from the North West Coast, and we've got local authorities here possibly as well. And so Many speakers, in fact, from today from the health services and academia. And so I'm Sarah Rogers, and I'm lead of the Care and Health Informatics team for the ARC North West Coast, and we've organised today's workshop. So we want to present the progress we've made, as John was saying, over the last couple of years in the North West Coast region. We've done this by working in partnership with health services, local authorities and academia. And we've done that working with the patient and population data. And I think there's been an acceleration in the speed with which we're using these types of data across the region. And of course, the similar over the UK-wide and globally, perhaps over the last couple of years. We've got Helen, our first speaker, who's going to come on and speak to you in a couple of minutes. She's one of the main instigators in accelerating this, the excellent work across the region. She's actually been leading the way over a longer time, originally based in Liverpool CCG, having managed, for example, to persuade our local GPs of the absolute importance of their data as an essential component of a data bank investigating population health. And so in our first session, we've also got Ben and Wes. Ben is an academic and the lead of the Improving Population Health theme in the ARC North West Coast. And Wes is the Director of Strategic Analytics at Merseycare NHS Trust. And they make an excellent team balancing the needs and priorities of health services and those of academic research. In fact, Wes is the member co-lead for the Improving Population Health theme of the ARC North West Coast. And so then, as John said in session 2, you'll hear about data linkage in the wider region and even some from Wales. And so now I'd like to invite Helen to begin her presentation. We'll have a few minutes for questions between presentations and then a longer time for discussion at the end. And then we've got a short break coming up as well after that. Great, so I'll hand over to Helen.
Hi everybody, just to check, can everybody see that?
We can. You've not got them on present. Oh, there you go. You got
there. That's changed. Yeah. Okay. Hi. So just to introduce myself, although Sarah did give a bit of an introduction there. So at the moment, I'm seconded into the Cheshire and Mersey ICS as the Associate Director of Business Intelligence. I've come from Liverpool CCG, so the route I took was the analytical route, and we did set up a patient level linked data set there for use, and we made a lot of progress, which is why, you know, Ben and Sarah's comments around Ben and Wes and myself being a good team, because that's where we've kind of come from. And I think really over the last 2 years through COVID, we've managed to accelerate, I think, the ability to analyse patient level linked data sets across the whole of the ICS, which I think has been an excellent acceleration. So I've got a presentation which is about 10 to 15 minutes just to take you through that journey a little bit and where we're at now. And it's not perfect, we've still got a lot of way to go, I've got to say, but it's pretty good about where we've got to. So just a little bit on population health, really, and I'm probably hopefully just teaching the whole audience, you know, something that they already know, but it's worth just starting with thinking about where why we're actually doing this. The stuff on the kind of right-hand side of these slides is more sort of technical about the component parts that you need for population health, but generally, you know, data and linked data is the real ability to be able for us to do this properly. And I think that's the main point that I wanted to say. There is also sort of, I think, two components to population health. There's population health in of itself, that's analytics that would generate insight and understanding of our population's health status and the inequalities between them. But then there is also analytics to support population health management. Now, this is more on the operational end of population health, whereby we're actually showing people populations that they could target with frontline services, often more proactively, in order to be able to, you know, manage health outcomes. And really my concern across Cheshire and Mersey ICS is both of these things. The first one I see is a bit more to inform planning and perform good decision making about how we allocate our money and how we can best, you know, target interventions. And the second one is much more about how we can target interventions at the right people and have maximum impact for the interventions that we provide. So the Combined Intelligence Population Health Action Programme was born probably within the first quarter of COVID in 2019, and it really stemmed from conversations that were already happening, but were then accelerated by the need for us to have linked patient-level intelligence in order to manage the pandemic. Since then, it has had investment across nationally into an expansion programme. So it is actually being rolled out across other care systems. So attention to the second top left box there around it being rolled out across 12 larger care systems. What is it? Well, it's a real-time linked patient level data asset. I'm an analyst, I'll always talk about the data, but it's much more than that. It's the ability then to create intelligence off that and bring strategic leadership, operational colleagues together around that intelligence to affect change and to improve health outcomes. So a bit on the data storage, and we're going to get a little bit more technical here, but hopefully still on diagrams that people will understand. What we did is we had a set of information sharing agreements that we rolled out across our ICS partners. So that included health and care, so mental health, community, acutes, GP systems, very important because they have a lot of rich data, some public health data flows and services, and social care, so adults and children's social care. And a big part of that in the first quarter was really winning those hearts and minds, I'm going to say, on the data sharing. I think that's COVID helped us. So COVID was a big ingredient in that because it gave people a real imperative to understand why that was important. And so we flow that data into an integration engine, and some of that feeds a shared care record in certain places in Cheshire and Mersey ICS and in the expansion programme. And then some of that then is pseudonymised and is made available for use for population health. So on the right-hand side there, you can see different use cases. And the one that we're most concerned with, I think, on this call is the analytics, which is the bottom use case there. I won't go into the information governance, but everyone knows how much I do love talking about that. So if anyone wants an explanation of that in the background, feel free to get in touch with me to understand how that system operates. This is a bit more of a detailed view of the types of data items that are in there. I'm thinking people on the call probably do understand a lot of what's in the data, but as you can see, that big blue box in the middle, which is GP practice data, has a lot of population health variables in it and is probably one of the main, like the backbone, I'm going to say, of our ability to understand population health outcomes. We then have the ability to link that data to lots of different other data sets, again, securely and in a pseudonymised way, so that we can't re-identify the patients. Getting a bit technical, but then there's a role-based access control that enables that data to be identified where it needs to, and it'll become clearer how we kind of do that as I move through the presentation. So the other components of this then, and I'm going to talk a little bit about the information governance here again, is that we obviously want to harness that data to be able to undertake research analytics in a secure way. So part of the plan now and moving forward is that we use that data to populate, I'm going to say, a secure trusted researcher environment. And essentially what that is a data warehouse where the data is all securely and pseudonymised, and researchers can request access to parts of that data depending on their research question. Now we have this rolled out, but we've only got it rolled out with permission to use it for COPI and COVID related purposes. So we are still on a journey around our ability to share this data for wider research problems.
The public do scrutinise us, and being able to...
Oh, sorry, should I carry on?
Yeah, please carry on. Would the other person mute themselves, please? Could we hear you? Thank you.
And I think that's quite important to sort of understand where we are on that journey, because really part of data sharing is massively about building trust with the data controllers that want to share the data. And so we're about to launch our trusted researcher environment data sharing agreement, and we need to go on a journey, I'd say, with our data controllers to understand, you know, the purposes and the use and why that is secure and what the controls are that are in place to do that. But the intention is absolutely there that we broaden out that access for broader purposes than COVID. So what have we been doing with the data across Cheshire and Mersey? So two examples here really. One is around supporting elective recovery and the other one is about improving health inequalities. So there's lots of use cases that we've developed for the wider use of population health, and some of them are listed here. And I'm just going to go into a couple of them briefly. So this is a hypertension use case where people can receive a BP at home monitor to get remote monitoring for their hypertension. Obviously a big area to prevent exacerbation and progression of disease if we can catch hypertension early and help with self-management. So what the system enables you to do is identify the cohorts who have hypertension and might benefit from a particular service. It then enables you to monitor those cohorts through data flows from the BP monitoring system remotely, and then understand in two ways: one, to manage the patient effectively through that pathway, but the other one then is to understand the aggregate view of your population to see if you're actually improving their health outcomes as a result of having that intervention. The next thing is around elective recovery, obviously a massive issue across the system post-COVID, and we have waiting lists that are ridiculously big now, and people on those waiting lists really do need to be kind of stratified and prioritised to make sure that we pick the right patients first in order to not exacerbate any health outcomes of those patients waiting. So what we've done across Cheshire and Mersey is we've actually stratified that waiting list for outcome using an algorithm that enables us to understand what the risk is of someone waiting on the waiting list. There is then very careful discussions around whether those people need to be reprioritised. This is only happening at the moment in St Helens and Knowsley because there's a lot of clinical implications for using the data in this way, but we're hoping to then roll that out in a wider way across the ICS to other provider trusts, and also use it as a means to be able to potentially redirect some of the high volume, low case mix waiters to maybe the independent sector providers, for example. So I think there's what we're seeing as some real tangible ways that we're using the data in order to improve population health. There's a Cheshire and Mersey work plan, and I'm not going to go into this too much because I'm probably nearing the end of my time, but there is a load of reporting set up to help us manage COVID basically, and it still exists, and we're now having some conversations about what's the legacy to that, as we're talking about moving out of a pandemic phase. We have a few other use cases again, which I'll circulate in the presentation, but basically evidence the kind of benefit of us being able to link the data. And I've talked about some of these already. Another one which I think Wes is going to talk about a little bit more is the Mental Health Explorer, so he will come on to that shortly. The final one I wanted to talk about is something called System P. So I really see this as the kind of action, the A in Cypher. So System P is basically a small commission project across Cheshire and Mersey ICS where we're going to really try and focus down on a couple of segments of the population to provide further insight. So we're maximising the use of the linked data for the frail, elderly population and people with complex lives, which is the trimorbidity of physical, mental and social health needs. And we're going to use the data to really explore the linkages in health outcomes across those segments. And I think I'm going to stop there. I was going to talk a little bit about the uptake of the population health data sharing, but actually I don't think that's probably that pertinent to this group. So I'm going to close there.
Thanks very much, Helen. That's really good to see how much has happened so quickly over the past couple of years and where we are now. You mentioned, I'll open it up to questions in a minute, but I was wondering whether I could just ask one first as Chair's prerogative. I was wondering whether you said at the beginning that it took hearts and minds to convince people to set up the system in the first place. And I wasn't really part of that process, but I'd be interested to know who were the people that you had to get on board, and what happens next if we're trying to open this up to researchers in a more sustained way rather than just for COVID purposes. What's next?
So this is really about people and people trusting other people and relationships. It will be my observation. So we had to do, I always call it, we had to do our time. We had to go and speak to people, and we had to find the people, because Cheshire and Mersey is massive. It is 2.7 million population. It's 16 providers. I probably got that quite slightly wrong, 357 GP practices. And what we had to do is find the people in each of those subsystems who were the trusted people, who the GPs or the data controllers already had existing data sharing relationships with, I'm going to say. And then we had to get them on board, and then through them we managed to get the GPs on board. And it's not just the GPs. I had to go to CIO meetings of the providers, the clinical information officers of all the providers. I had to go and see the medical directors of the providers. So really you had to find the people that could be convinced that it was the right thing to do in terms of using the data. But then you had to go to the next layer, which was the people who didn't think it was secure to share the data. So you had to find both of those sets of people, and then you had to do the time with the conversation. What's your issues? You know, how can we reassure you? You know, and have the conversation. So I'd say it was probably two sets of people: the kind of strategic leaders to get the buy-in, and then the technical people. What I would say really helped us was there was chief exec buy-in, and enough of that across the ICS. Like that leadership, I'm going to say, that you had the air cover to then go and have the conversation with the information governance manager that potentially didn't want to share the data. That makes it sound hard, but, you know, were more worried about sharing the data. So, yeah, you've just got to have the conversation.
Great, thanks, Helen. I'd like to open it up to any other questions. I know there's a couple of things in the chat. Would one of you, Mark, maybe, would you like to ask your question? Oh, and then we've got John as well. Do you want to state your question, Mark? Yeah.
Yeah, thanks, Sarah. Very, very sort of like highfalutin and a discussion point in itself, but just really one for you, Helen, is that would this shared data approach support a longer term merger of physical and mental health, so we just become a health service? I know it's a sort of like long-term pitch, but
yeah, I think it does, because what it can do is it enables you to create the analytics that exposes that relationship between the two. And I mean, Wes is on, and Wes will probably talk about all about this, but I think it is a means to an end, if that makes sense. But in the same token, between health and care, we have all these boundaries, don't we? And I think that the more you can produce intelligence that doesn't silo the problem to institutions and actually enables you to describe a person's health and social status, if that makes sense, as opposed to they've admitted to hospital, you know, they've been to a GP and this thing was wrong with them, you know, they've been to a mental health service. That I do definitely think that it can help with that through the analytics that we produce.
Thanks, Helen.
I think we've got time for John to ask his question, and then we'll have to move on to Ben's talk.
Okay, thanks, Sarah. So I'll be really quick. I mean, that was fantastic, Helen. So the first quick question, you mentioned about this being spread nationally beyond Cheshire and Merseyside. Is this the same cipher that's the collaboration with GraphNet? Is that how it's? Yeah, right. So thanks for clarifying that. And the other thing was, I actually didn't realise that all of this was copy dependent. I mean, so what's going to happen in July?
So so it is a bit complicated, but supposed to try and be brief. It's not copy dependent if you're a data controller within Cheshire and Mersey ICS. So we have managed to put the data sharing onto a broader footing. But it's still copy dependent for kind of the research imperative. So we've got some agreements that we need to put in place with the Cheshire and Mersey data controllers to enable to use the data for research for broader population health purposes. And also with NHS Digital, which is actually the slightly more tricky one, I'm going to say. So yeah, hopefully that answers the question.
No, it does. Thanks.
Right, so we'll have to move on now, and so I invite Ben to give his presentation. Welcome, Ben.
Great, thanks, Sarah. Just share my screen. So hopefully you can see that okay. Yeah, so just to remind people who I am. So I'm Ben Barr. I'm a professor in applied public health research at the University of Liverpool. Yeah, and so I'm going to sort of follow up on what Helen has been saying really about how we've used the kind of data that she's been describing to evaluate policy and practice in Cheshire and Merseyside. So a little bit about the journey that we've been taking for that and the way of working, and some examples of evaluations, sort of rapid evaluations that we've developed as part of that work. So it's been sort of a fairly sort of long journey, or it feels like a long journey. Back in 2018, Helen and I got a small grant with the CCG from the Health Foundation for what we called the RICE tool, Real World Intervention Causal Analysis or Evaluation, I think it was. So that really sort of funded having a researcher from the university embedded within Liverpool CCG's business intelligence team, and that really kind of sort of established this different way of working of embedding the researchers with NHS and local government business intelligence teams, enabling them to both sort of understand what the priorities are within the local system and be able to sort of respond fairly quickly to those. And that's kind of what we've been trying to develop. And as Helen has mentioned, that with the pandemic, that moved in onto a sort of larger footprint across Cheshire and Merseyside with the establishment of CIFA. Other things that sort of have helped with that, we also got an HR grant called Restore, which was really about funding that was available to build on sort of lessons learnt and the experience of the pandemic to help with the system recovery following the pandemic. And as Helen has mentioned, that's sort of leading into a sort of wider program of work called System P, which is then applying some of these analytics in order to try and inform service design. So all of this is really about trying to embed those sort of analytics using these large linked data sets as part of a learning health system. So there are sort of two elements where the data comes in particular. One is identifying needs and risk groups within the population, better characterizing that so we can intervene in the right place and the right time with the right people, using that to redesign systems to better achieve that, and then evaluating whether those redesigns of services is having an impact. And really I'm sort of focusing on the evaluation part of this here. So we have a team that's sort of embedded within the local system with the CCG and the integrated care system. One of the sort of fundamental issues of trying to evaluate whether a particular intervention has worked is trying to work out what would have happened if you hadn't had that intervention. And the kind of basic method is, well, one, identifying the people within those records who have received some intervention, and then using the data on the people that haven't received that intervention to construct some kind of comparison or control group to look at how the outcomes changed for those who received the intervention compared to those who didn't. So that in this initial bit of work, we tried to set up systems with the CCG to try and streamline some of that process. Well, initially we had a long list of projects that we were hoping to be able to evaluate. Some of those we did manage to do, but priorities kind of changed rapidly, and of course the pandemic came along and there were a different set of priorities. But I guess one of the things was being embedded within that system, that we were able to kind of adapt to those changing priorities. So, as I say, the basic kind of approach is identifying a cohort of people who have received an intervention through a process of either sort of matching or weighting people who haven't received that intervention, constructing a control group of people who are, as far as we can tell from the data, similar to the people who received the intervention, and comparing how outcomes changed before and after the intervention in those two groups. There's a kind of approach that's sometimes called difference and differences, but this also sort of combined with some matching approaches for those different populations. There's a number of different methods that I won't go into in detail, but we'll talk about in some of the examples. But for each of these kind of evaluation processes, well, there's a lot more to it than just getting the data and being able to access the data. And that is a process that really relies on people being embedded within that system and having those relationships, both with the commissioners and providers of services, to really understand. So understanding the intervention and what has actually happened and how it's different from what was happening before and how it's different from what's happening in other places. Particularly in order to look at aspects of how people are exposed or included in that intervention that can help you assess the causal impact of the intervention on outcomes. And then, of course, there is a whole set of issues of understanding the data, and pretty well with every sort of new project, there are new data issues. And how are we going to measure who was included in the intervention? That's the first kind of issue, as well as the other potential sort of confounders in the data that you need to take into account of. And that generally involves getting additional data from people providing the interventions, at least so we can identify, we can flag people in the data set who have received the intervention, but also getting information about kind of the intensity of the intervention that they've received. And all of that, relies on having those relationships. But also this process helps build trust for further data linkages and feeding in data. When you're when you're addressing a problem that's been identified as a priority by the data owners, then they're clearly going to be much more inclined to support data linkage. So that's the kind of process with the linked data within Cheshire and Merseyside, and that has enabled us to look at evaluations where we're kind of constructing the intervention and comparison groups from the population of Liverpool and Cheshire and Merseyside. We also have this other data resource called the place-based longitudinal data resource that has a whole set of indicators at small geographical levels over time across the whole of England. And we also use that in some of these evaluations where we need to sample a comparison population from outside of Cheshire and Merseyside, which was the case for some of the COVID related work where we have interventions that are being implemented across the whole of the region. So just to give a few examples of evaluations that we have carried out using this approach. So one of the first things we looked at was this introduction of a new model of integrated care teams in Liverpool, and could identify the cohort of patients who have been through that intervention. And one of the aims of that was to one of the aims of the integrated care teams was to reduce emergency admissions to hospital. So we're able to identify that group of people, match them to a similar group of people who had similar kind of trajectory of hospital admissions before the intervention, and then compare between those two groups. And that basically showed that the intervention hadn't sort of achieved that aim anyway of reducing emergency admissions. And in fact, there was a slight increase in emergency admissions in the intervention group. And actually that similar findings have been found for those kind of interventions across a number of studies. The second service that we looked at was looking at evaluating a new end-of-life pathway that was introduced in Liverpool. And that presented some sort of new methodological problems, partly because you could no longer compare people before and after they had received the intervention for obvious reasons. So yeah, having an intervention where at the end of the intervention everyone has died does present a few sort of methodological issues. But we could compare two different cohorts sort of before they had introduced this new service to afterwards, and basically looked at the trajectories of hospital admissions up until the point of death of people who were on this pathway and people who weren't, and also compared that to more than 90 days before their death and shorter than 90 days before their death. So we could use those comparisons to come up with an estimate of what impact the new end-of-life pathway was having on emergency hospital admissions in the 90 days before death, and that showed quite a marked reduction in those with the new pathway. So demonstrating that that intervention had actually significantly reduced the chances of people having emergency admissions in the 90 days before they died. When the pandemic came along, obviously we pivoted a lot of this to evaluating work to support the response to the pandemic. One of the things that you may have heard about is the introduction as part of a national pilot in Liverpool of mass testing that came to be called smart testing, but basically use of lateral flow tests into widespread community testing. So as part of that national pilot, we evaluated the impact of that on hospital admissions for COVID-19. For that, because that was introduced across Liverpool City region, we actually used small area data for hospital admissions over time and used this approach called synthetic control analysis, where we basically match the small areas of Liverpool, so small neighbourhoods, with places that had a similar sort of trajectory in terms of COVID-19 transmission prior to the point when the smart testing was introduced, and use that to look at what impact that had on hospital admissions in Liverpool. So it sort of showed at the beginning, when there was quite a 25% of the population was tested within a couple of weeks in Liverpool, where particularly when the military was involved in supporting that did seem to have some short-term effects on hospital admissions. One of the things that we've sort of followed up on that was looking at the sort of vaccine rollout and interventions to try and improve uptake in vaccines in more disadvantaged areas where there was low vaccine uptake, where local authorities across and CCGs across Cheshire and Merseyside basically invested in mobile vaccination units that visited different neighbourhoods. So we took the data from where those vaccination units had been sited and linked that with the data from Cypher on where people lived. So we could basically identify people that were in the neighbourhoods that had been visited by those mobile units and compared them to a control group of other neighbourhoods that were similar in terms of their vaccine uptake, and basically demonstrated that that intervention did increase a sort of relative effect on improving vaccine uptake of about 22%. So that's just some of the examples of ways that we have managed to sort of relatively rapidly respond to needs from the local system and to deliver that kind of evaluation. It's definitely quite a few challenges in doing that, and it does rely on having those sort of sustained relationships with the sort of local health and care system. And as everyone knows, the health and care system is, you know, continuously being reorganized and changing, so that always adds additional challenges. Yeah, and that this kind of sort of rapid response doesn't always sort of fit well with the kind of time cycles that academia normally runs on with sort of research grants. So that's a sort of additional challenge. Obviously, the data is limited to what you can measure within the data. We're generally just looking at outcomes defined in terms of use of services, not much within the data on actual measures like quality of life. There's a number of biases, of course, in terms of the way, you know, the extent to which you can use those kind of methods to identify causal effects of interventions. One of the things that often takes the most time is actually getting good information describing what the interventions were and how they differed from what was happening before, and what other interventions might be happening at the same time. So this is almost, you know, becoming established as a kind of way of working, and we have a sort of team of analysts that are supporting the System P work to better, you know, focus on, you know, as we come out of the pandemic, hopefully focusing on how we can sort of use these kinds of approaches to better you know, inform service design and improve the use of data and analytics within sort of local decision making. Thank you.
Great, thanks very much, Ben. You managed to talk for your full 15 minutes. So what we'll do is we'll go straight into questions, straight into Wes's presentation. And then what I think we can do, so if you stop sharing, and then we'll let Wes start sharing his screen. And while I'm talking, if you save up all your questions, and we'll ask them in the discussion section before we have a break. So thanks very much, Ben. And over to you, Wes.
Hi everyone, my name is Wes Baker. I'm Director of Strategic Analytics, Economics and Population Health Management at Merseycare. I'm going to deviate slightly away from doing something in slides, and I'm going to show you a video of System P, which is, and I'm just going to maximize this. So let me know if you can't hear this.
System P helps partners providing health, social care and wider support to share knowledge, learn from it, and then work together to provide care more effectively. The process is split into 4 elements: data, analytics, care, and payment. By linking up what we know and analysing it with AI, we can spot gaps, overlaps and correlations, and show up opportunities where small changes to the system can make a big difference to health outcomes for our population. Currently, as people's needs become more complex, so can their care. In the System P model, partner organisations share responsibility and pool some of their resources as they work together to simplify how people can access services and attempt to solve the interlinked problems that prevent health outcomes improvement. To help us do this, System P divides the population into segments according to their health status, healthcare needs and priorities. To start with, we will focus on 2 quite different groups who both have significant care needs. What follows is an example of how System P can help us better provide for the unique needs of the growing frailty and dementia population segment who don't always have the best experiences or outcomes. There is often an overlap between frailty and dementia, as a deterioration in physical health can impact mental health and vice versa. The shared data and AI analysis of System P helps us see how many other socio-economic factors also combine to multiply and strengthen the barriers that prevent the frailty and dementia segment from keeping well. It's very difficult to significantly impact any one issue in isolation and impractical for a single service to address them all. But by sharing knowledge, responsibility and resources, System P can help us to combine and coordinate our responses, allowing us to reduce and remove barriers to wellness and therefore provide better outcomes across the board. Identified as having a range of different risk factors, the complex lives segment of the population face their own unique set of issues and barriers to keeping well. These can be practical, psychological, or even attitudinal issues within the institutions that provide their care. This segment draws upon a great many mostly reactive services at great expense, often without seeing a significant improvement in their outcomes. While the solutions will be very different to those we looked at in the frailty and dementia segment, the principle is the same. One service working in isolation can easily be overwhelmed by this interlinked combination of issues and simultaneously be unable to make even a simple intervention stick without taking them all into account. Here, a well-informed overview based on real local data can help groups of services to identify trends, patterns, and system opportunities for earlier and more effective interventions. And by pooling resources and sharing responsibility, gain the opportunity to switch from reactive to proactive care as we work together to reduce risk factors and improve outcomes in a more joined-up way.
So I'll just share the screen. So what we originally found when we've done transformation in the past is that there's something that always falls down, whether you don't have the data, you don't have the analytical capability, or an intervention goes into place and then the financing doesn't happen because the accountants or the directors of finance aren't engaged in the project and don't see the benefits. While System P tackles all of those four pillars, and it starts with the data from Cypher. So Cypher is effectively the foundation of where we can do this type of information, do this predictive analysis and analytics, and using the assets within the university. So we've got epidemiologists, health economists, data scientists, and maximizing the resources within those assets within places, and moving away sometimes from kind of consultancy organizations like the Big Four, who seem to be the go-to for most NHS organizations or places when they want to do this type of transformation. So System P is, as the video says, is focused on two areas: complex lives and frailty dementia. Complex lives is someone with a physical and long-term mental health long-term condition, and they have substance abuse, history of offending, homelessness. And we delivered the hackathon event last year with the Cheshire Merseyside system, where they came and asked us what are the key lines of inquiries that we need to start to ask the questions within the data. And we've now got a list together, and we're working at about April to release packs for each place and for the ICS as well, so we can share for that integrated care system for Cheshire Merseyside, identify what are the numbers of people we're talking about in terms of frailty, dementia and complex lives, and then for each place and going even further down to every primary care network, so places can take action. And then we're going to do some targeted work with two places, one for frailty, dementia, one complex lives, using the resources within the university in a partnership way. The view is, once we've done an intervention, delivered the outcomes and supported the transformation with finance, we'll try to scale that across the integrated care system, across Cheshire Merseyside, so everyone gets the benefits. It's not one size fits all. It's about sharing what you could use and what you would want to tailor within your place. Something might work in Cheshire may not work in Knowsley like for like, but you may take some of the best bits and tailor and change it for your needs of your population. And finally, we have directors of finance involved in the project as part of the reference group, so they're interlinked within this System P project and portfolio of work. I think I've made up some time there for you, Sarah.
Excellent, thanks, Wes. So I'd like to open the floor to questions, either for Wes or Ben at this point. Does anyone have any questions for us? I can ask one if no one else has got one. No, we're being very quiet. Okay, so I want to ask Ben about the data issues. You said that there's always data issues with every new project. And I was thinking that surely if we use data over time, eventually we'll reduce some of those issues. But I was wondering how we can best share the learning from each of these projects in a way that will sort of disseminate throughout the, all of this group essentially, so that we can all learn from some of those issues and avoid them in the future.
Yes, I mean, there's data, there's making sure that we only do something once when we've worked out a way to do it, and quite often we're doing things across similar data sets but different kind of cuts of the data and different so having a system where everyone kind of pools their analysis and analysis that's been written here on those data so that it can be reused, and doing that in ways that are kind of more reproducible, which people like Ollie are helping us with. We haven't always necessarily done as well as we could have done in the past. But I think one of the issues that is often hardest is actually getting sort of information about specific, so enhancing the linked data sets with information about specific interventions and who's received particular interventions, which isn't necessarily sort of routinely coded in kind of standard NHS data sets. So getting better systems for that, I think, would be useful.
So that's the data that, oh, sorry, Helen, did you have a question? And John, I don't know who was first, sorry, not very good at this.
No, mine wasn't really a question, it was more of an observation in relation to your question, which is that I think that we spend a lot of time trying to get the data, and actually we've got a phenomenal, when you get the data, it's a phenomenal amount of data. And actually, I think people who are kind of in receipt of that in order to undertake, pieces of work, I'm going to say pieces of analytics, probably really need to, we've still got to go on a massive journey once we've mobilized the data to really understand it and the structure and share that code. And I think every time we've done a project of this type, and Ben will, we witness to this in his team, we underestimate the amount of time, even for the most experienced data scientists or data wrangler, to actually get to grips with these such big data sets. And also they are fraught with data quality issues, some of them, so we collect a lot, but I think we've got a lot of work to do to kind of, understand them, standardize them, and share our learning on how to query them.
Yeah, I think that's a common issue that I've come across before, Helen, about the time it takes to unravel those data and truly understand them. John, have you got a question?
Yeah, well, I mean, thanks, Sarah. In some senses, it leads on from that, and it was something that Ben touched on in his presentation. I mean, I think I hope it goes without saying that I think the work you're doing is fantastic, but obviously it's challenging, and I just wondered about your experience of some of those challenges. I mean, and the main, what we're trying to do is make some sort of causal inference in these data, which allows us to answer questions about what works and what provides value. And the main challenge to that is, you talked about selection biases. Another term that's sometimes applied to it is confounding by indication. People get interventions for a reason, and generally the reason they get the intervention can influence the outcome that you're interested in as well. So, I just not really necessarily a technical answer, just based on your experience of trying to do this, to what extent do you think you're able to overcome this and avoid coming to conclusions like being prescribed salbutamol makes you wheezy?
Yeah. No, I think that's clearly the methodological challenge. And I guess, one of the things that makes it easier is if health services are not very precise in how they allocate resources and interventions to particular intervention. The more precise the health service becomes at better targeting the right group of people, probably these methodological problems get harder. But there is a lot of often, where things get rolled out, whether it's just certain GP practices or, with some of the sort of COVID work, or we had the vaccination units, different local authorities started at different times and used very sort of different criteria, and some of the other sort of new services, when they do get rolled out, they're not being rolled out to everyone who meets the criteria for that service at the same time. There's a lot of randomness in the way health services are delivered, and that's something that we can sort of utilize in that sense. But I think it becomes harder when, especially when you've got services that are rolled out on a very large scale, kind of quickly, for a very particular kind of cohort of patients or members of the public.
Yeah, perhaps we, in some ways, as academics, if we're lending them our analytical expertise, we should make sure that there's an element of advisory in the rollout as well. To enable maybe not randomization, but some sort of component as we.
I mean, ideally it would be influencing that rollout of interventions in a way that enhances your ability to make those causal inferences.
Yeah, great. We've got a question from Graham Evans.
Yeah, hi. Sorry, I'm an interloper from Sussex that was just really intrigued by your topic. So join the call, perhaps. Okay. I was just interested in whether you were using your integrated data set to re-identify patients in terms of thinking about identifying cohorts within population health management to work with, and whether that caused any sort of IG issues about, when you'd ask for data from providers, were they keen or not keen for that re-identification to happen?
So yeah, I can take that one. They are keen for that to happen. Certainly. So through COVID, we had acute providers who wanted a lot of information on the patients who were turning up in for example, their vaccination status, or with the recent rollout of the MMAB service, which is about the antivirals for people who are vulnerable, who catch COVID. If we've done an algorithm that can re-identify those patients, so that there is a real kind of clinical, and I'm going to say use for the direct care use for the identifiable data. Where we could identify a use case that was of benefit to them, they were really interested. Where what switches them off is a discussion around us just being able to take data and re-identify it for the sake of it. So my observation is they need something tangible. They need something that they can really point at and go, it's these 4 clinicians, and the reason why they're accessing that data is for this. So the harder conversations, I think, are with, for example, at the moment, maybe some of the PCNs or practices that don't see that they have the time to risk stratify and find, proactively find patients to give them an integrated care review, for example, which is a very real issue. Not all practices are like that, and I can see that why they're busy, but they're a bit more like, well, why the conversations we have aren't so much around the ID and re-ID part. It's just much more around, well, why is this useful to me, and what resource are you going to give me to do this? I don't know. Yeah.
Thank you.
I know we've got a few of our public advisors from the Northwest Coast here. I wonder whether any of them have a view on that sort of re-identification component, because that's one thing, isn't it, having all the data in an anonymized way or pseudonymized way, but then having the ability to re-identify it. I guess having put it like that, Helen, I think there's a direct care case but I thought that's an interesting point, that we have the ability potentially to re-identify people. Maybe that's something for the discussion breakout room, if not now. So is there one last question that anyone would like to ask before we go into a short comfort tea break this afternoon? I see that people have been busy asking questions in the chat, and people have been answering, which is good to see. Right, in that case,
Sarah, I was just going to say, Sarah, just a quick thing. So someone made a comment about the physical and mental health integration. Yep. And one work we are doing in Cypher is called the Mental Health Explorer dashboard. And what that dashboard did was it identified that for mental health service users, the second most common long-term condition for them is obesity. But what we tend to find nationally is funding there's a pot of money for obesity and there's a pot of money over here for mental health. And what we're trying to say is actually we need a pot of money that joins some of that, a bit of mental health, a bit of obesity brought together to tackle that. So this is starting to show that, and that's happening within places. We've had the same issue with certain places who have pots of money allocated for interventions, but they see the problems as two separate components and sometimes the same group of people you're trying to target.
Yeah. Well, I'm talking later this afternoon about a green-blue space intervention, or not a natural experiment, an observational study really, about how people can visit outdoor spaces, and it's good for their mental health and it's possibly good for their physical activity too. So that's a nice segue into that for later. So thank you everyone for your attention so far. It's just time now for a little break. So we're coming back at 1:15, so you've got 10 minutes to get a cup of tea, etc. And then we're going to hear from Joe Knight, myself, and Pete and Ollie this afternoon. So see you back here at 1:15. Thank you. Come back, everyone. I'm going to hand over to John in a minute to chair the next session. I just wanted to check that lots of people were back, because I can't tell with all your cameras off. I'm sure you're all there. So without further ado, I'll hand over to John to chair this next session. Oh, we've got Jo. She's an important one.
She's our first speaker.
Yes.
Yeah, thanks very much, Sarah. So we should get started. So welcome back, everybody, to the next session of this afternoon's meeting, where we're going to hear more about data linkage, both in the Northwest Coast and beyond. Personally, I found the first session really fascinating and really useful in terms of informing my thinking around what we're trying to do here in the west of England, which is very similar to what you're trying to do in terms of using our data better to drive health improvement. And I hope that colleagues from other parts of the country who are also joining the meeting have found it as useful. So in this next session, we're going to hear more about the work in the Northwest, and as I say, beyond. We've got several speakers, and then we've got a breakout session just after 3 o'clock. So I think I should move to the first speaker, who's Joe Knight, who's going to talk about corralling data from NHS trusts for health research. I'll hand over to you, Joe.
Hiya. As we came back after the break, as Sarah said, welcome, my Zoom just completely disappeared. I'm hoping that's not going to happen again. I don't know why it happened, so hopefully it won't. Right, I tried to test sharing the slides in the break. Can you see that? Good, okay. And I just need to make sure. Okay, Sarah, can you do me a favor and give me a 10-minute warning? Oh no, hang on. You want me to give time for questions, don't you?
You've got a good 10 minutes to talk, and then we've got a few minutes after that for questions.
Okay, so give me an 8-minute warning so that I make sure I wrap up in time.
Verbally or in the chat?
I don't mind.
Okay.
Verbally is probably better.
Verbally.
I might not see the chat. Yeah.
Okay.
Yeah. Okay. So I'm talking about corralling data from NHS Trust for Health Research. And I said very clearly, this is not all my work, and these are some of the other people involved. This plot was a bit more interesting when I had 3 Rachels, because I thought it was quite interesting as a statistical distribution that among quite a small group, I had 3 Rachels, 2 Emmas, and then a selection of other people. But anyway, I've only got 2 now, so it's slightly less exciting statistically. But these are the people on the photos here are the people that who are working with me currently as PhD or MD students, doing things with routinely collected data. Their co-supervisors or co-Is on grants are also listed, and the funders also listed. So this is kind of acknowledgement of all the people doing the different kinds of work that I'm going to talk about. And I know I've got sort of 8 minutes, so it will be quick, but I'm going to what I said I'd do is cover the range of things that I think you can do with routinely collected data. And so that's what I'm going to try and give you a taster of. So we're going to look a little bit at neurology services. In terms of vaccination coverage and respiratory disease treatment, we won't go over those quite as much, or digital technology, but I'm also going to look at COVID in care homes. So the top one and the bottom one, I'll show you a few slides on each of those, but the middle ones I will just introduce verbally now. So in terms of vaccination coverage, that's actually it's a work trying to use the routinely collected data to understand whether or not it's a good idea to make an intervention in A&E, in children's paediatric A&E, to talk to families about whether their kids are fully vaccinated and perhaps get them fully vaccinated. So it's well known vaccination states are not what they should be, and that's become even more apparent during COVID. Some of the children that turn up in A&E may not be having other routine primary care appointments and things like that. So this is a really good time for an intervention. And we're basically using the routinely collected data that sits on the summary care record to currently assess both the levels of vaccination and the levels of correct recall among parents in that situation to see what can be done. So that's just an example of how you might use it for population health cover. In the respiratory disease treatment and diagnosis, that's actually a project working in partnership with Morecambe Bay have a respiratory disease network where they've worked really hard to try and get people onto more care that will prevent them getting more seriously ill. So routine care, checkups, interventions that happen sooner than that. For example, an exacerbation in COPD might lead them into an emergency care, and it's evaluating how effective that kind of network has been by using routinely collected care on the number of referrals are being made and what things are affecting those referrals, and whether indeed having the network rolled out is affecting the referral rate in respiratory care. I have to say, respiratory care obviously is an area that's been quite heavily affected by COVID, so that's been a bit challenging, but nevertheless, that's still ongoing. And the digital technology in care homes, that's a project linked to the COVID in care homes project, but was actually about, again, understanding using routinely collected data, so data that sits in NHS Trust, the benefits of digital interventions into care homes. So basically seeing whether or not the patterns of care change for the better for individuals once you had technology embedded in them. So these are all very different things, and I'll talk about them, some of them a bit more, but you can see the range of things that you can think about. Okay, so the pain of working with routinely collected data, and I'm sorry I didn't hear all the talks, so I'm sure I will cover some of the same things, but from my perspective, the pain, one of the things is I've worked, and this was perhaps not a clever decision from the beginning, this work covers 4 main NHS trusts, so I can't even get this right in one place and then keep going. I keep having different trusts who want to do things in different ways and have different members of staff and different structures in their way they might approach and do this, and that creates an additional challenge. So sometimes we go through IRS and sometimes we go through service evaluation, depending on what we're doing. And actually, to be completely honest, depending on the way that people interpret something as research or not. And although there's very clear guidelines, in some sense, through the Health Research Authority, and who should and shouldn't do an IRAS form, that doesn't translate completely into, although they look very clear, when you're actually on the ground and looking at it from all different directions, I don't think it really translates. So then you might have to instead go through the other route, which includes information sharing agreements, data privacy impact assessment, and data processing agreements. So it's another route. Obviously, there's ethics, there's sponsorship to think about if you're going through IRAS. And with both of those routes, those two things can be different, again, depending on who's doing the sponsorship, the university or the trust. And with ethics, all of the different institutions have different ways of dealing with that. So even if you go through IRAS, your own university will need an ethics, so it's quite complicated. There's lots of different trainings that can be done. And in fact, you end up doing a lot of different training depending on who you're accessing the data through. So because we work with different trusted research environments, people have asked us to do ONS training, MRC training, all of these different ways of training to make sure you know what you're doing with the data. So training's good, but again, it's a bit of a heterogeneous bag as to what you might be asked to do. The data is in different parts of the system. So even once you get inside the NHS, it's not even within one secondary care unit necessarily well linked together for a patient. For example, and we find problems in the data. So we don't think there's anyone that's sat in A&E for 4 months. So I know A&E's got problems, but they're not that bad. So we find things that we know completely aren't true. For example, we know we had the person in our data who's 100 centimeters tall and wide. It clearly doesn't exist. And so there are challenges and pain with data, and it's the real world. So these are things that I have been told by a number of my collaborators who are great collaborators. Hold the line, we're a bit preoccupied with the pandemic. That one's obviously been common for a while. Sorry, I was late, my patient's bleeding out. That's one I've had. And sorry, I have to go, I've got to put my hands inside someone's abdomen. So these are not things that you can tell someone, no, I'm sorry, my meeting's more important than that person who's bleeding out. And that is a challenge of working in a clinical system, that sometimes research hits the back burner. But the gain is we've got an incredible range in the data. This is everybody, maybe not quite everybody, but it's more everybody than you might get in lots of research projects. And there's a huge amount of data, and we can have a real impact and change health outcomes for people. There is help. Health Research Authority, who run IRAS, the way of getting ethical approval for NHS collaboration now, has done a lot of work to make it easier and provide a lot of training. There's the MRC regulatory unit that has fantastic soundbite training on all the different things that you need to understand, like who's who and what their roles are. And internal, I put in very small types our support pages because they won't be relevant for everyone, but lots of institutions have these. And I also recommend chocolate and after 6, perhaps gin. But there's ways to get through this if you're persistent. So just a snapshot of what is it worth it? In neurology, we started off with a systematic review. This isn't routinely collected data. This is what other people did with routinely collected data in neurology. And you can see at the bottom here, we've got, we looked at all the different papers that other people have done, looked at kind of the study objectives. A lot of what had been done with routinely collected data was just population characterization initially. And the other thing we did was think about what conditions were being studied with routinely collected data. So you can see from these figures, just at a glance, that, for example, multiple sclerosis is really heavily studied with routinely collected data. In fact, it's one of the ones that's actually used with routinely collected data and brought that into trials. But multiple sclerosis, epilepsy, they account for 60% of the total papers, and they are really important. But multiple sclerosis ranks 14th out of 15 in the global disease, daily rates, so sort of measures of quality of life. Migraine, which is only 4% of the studies, ranks highest after stroke in neurological impact. So I'm not telling anyone not to do research on MS. I'm just saying that when we look at the research that's done, sometimes we're doing it on things that are affecting less of the population. So it's worth looking at what's been done before you jump in. So having looked at that, we're doing some study on headaches because headaches does affect a great degree of the population and has a massive impact on neurology services. Sometimes possibly inappropriately, when actually it's the MS and the epilepsy patients who need to get seen because they're the ones who there are possible interventions for, perhaps. So it's all balancing these different things. So we had this paper looking at the variation of waiting times by diagnostic category. When we submitted this paper to bioarchives, we didn't have the comma in 1,951 referrals, and somebody actually wrote a comment to us saying that they thought lots of routinely collected data studies were out of date, and ours was particularly out of date because it was patients referred in 1951. It was actually 1,951 patients, and the data was collected from 2016 through to 2018. So a little bit out of date, but not as out of date as they thought it was.
That's your warning.
That's my 8 minutes. Okay. So this is clinically collected data in a hospital outpatient clinic connected to admin data. We were able to demonstrate that basically time from referral to appointment was different depending on your diagnosis, which isn't something that is necessarily always supposed to be, although certain patients, this is removing people who've gone through the 2-week really quick waiting list. So it's different according to diagnosis. There are a lot of people with seizures and epilepsy being seen much more quickly than other people, but headache patients are still being seen quite quickly. And one of the problems with that is that when you look at what happens to them, a lot of them are discharged. So there's a question of, should they be made to wait to see a neurologist? Should they not be cared for in primary care if once they see a neurologist, they're discharged? And should that give better care to them and better care to others? So with waiting times, we were able to draw some interesting take-home messages. We've moved on to a study looking at perhaps there's some CCGs referring more patients than other CCGs, and can we directly work with GPs to understand why they're doing more or less referral? At the moment, we're not seeing many that are out of the boundaries we'd expect, and there's more work that needs to be done on this. But again, it's using routinely collected data to say, are some GPs basically referring more than others? And then we might get into what the reasons might be. And in about 1 minute, care homes. I don't think I need to explain why COVID was important in care homes. Basically, they were a population that was incredibly vulnerable and incredibly implicated by that. We have a massive data set, I would argue. So we have total number of observations are about 10 million. This is actually the Northeast. I hope that's okay, even though we're talking about the Northwest today. And basically, this is all of the routine care and a number of trusts in the Northeast. From that, we then selected a cohort of care home residents, and we are looking at the trajectories over time. And so unlike, for example, HES data, we are able to follow the person through 2 years of care and say what happened on every single day, what were the changes that were made, where were they in AE, when do they go to inpatients and things like that. So we do a state sequence analysis on that. This is a random sample of our patients when they joined the care home. So there's about 20 of them in this. When they joined the care home, the different days they had different things. And then the black bars are when the individual has deceased. And so you can see, there's someone there who had quite a lot of inpatient care. There's other people who are darker grey who have lots of care within the care home. And then we cluster these. And then we get clusters that are based on kind of inpatients, outpatients and stuff. And we look for association between those clusters. And so we say, for example, are the individuals who are inpatients more likely to have, we cluster them based after their COVID test, a positive COVID test, and we say, are those individuals more likely to have dementia or diabetes or something like that? And we use that from inpatient care records. So that was a very quick overview, and hopefully you could see the photos in the bottom. So I didn't give the two individuals credit. Fran did a lot of the work alongside Hedley Emsley on the neurology work, and Alex Garner has worked with a few of the other members of the group on the care home work. Thank you.
Thanks very much, Jo. We've got time for one, maybe two questions. So does anybody have any questions for Jo? Either put your hand up electronically or physically. I can only see 4 people at the moment, so I can't see anybody with a hand up, and I can't see any questions in the chat. But
there's one about the quality of the care.
Okay, thanks, Jo. I hadn't. All the ones I saw were about defining acronyms. If you answer that, if you want to answer that question,
let me just read it again. So I'll read it out. I would worry about the quality of acute services data. My experience is with 3 admissions for seizure, in brackets dementia, was that there was no neurology input before, during or after the event, but they were determined to tag it to some other condition. Yes, I am worried about the quality of this data. This data wasn't collected for research. It's collected for care, and even in care, it's collected for a whole variety of reasons, for example, commissioning. However, I still think that we can gain a lot of information from it. I would also say that we're tackling this problem, actually, this specific problem, in another study using routinely collected data in partnership with OHID, so the Office of Health, I always get this wrong, formerly called PHE, Public Health England, now the Office of Health and Disparities, Inequalities and Disparities. Anyway, we're working with them, and we are specifically looking at people who have any kind of a tag for neurology emergency episodes at the moment, and looking at how long they were under the care of a neurologist, or whether they saw a neurologist at all, and then how long they stayed in the hospital, and trying to answer different questions like that. So I recognise the problems. I know that trying to answer the questions with data that isn't great won't necessarily get to the root of the problem, but we can at least explore variations and then maybe raise some stuff that might lead to further exploration.
Thanks, Joe. I think that's probably us at the end of our time. So that was a great presentation. Fascinating stuff. Next up, we've got Sarah to talk about system-wide evidence on health inequality generated using multisectoral data linkage. So I'll pass over to Sarah.
Thanks, John. So let me work out how to share this. Okay, great. So hopefully you can see my slides there. So yeah, as John said, and I think I said earlier, I'm Sarah Rogers. I'm part of the ARC Northwest Coast, and I like working with different types of routinely collected health, education, environment data linked together to work out how to best evidence changes that are needed for our cities, so that everyone has the opportunity to benefit from health promoting facilities, so parks, walkable streets, or good quality housing, for instance, as part of their daily lives. So I'm going to show you some examples today where we've linked data across multiple healthcare providers for the same person, and then move to a wider perspective, linking data over many different organisations, including using local authority housing and mapping data to look at the impact of the built and social environment on healthcare utilisation. And I thought I'd finish by giving you some thoughts on the essential ingredients of data systems that might allow this to happen. Although many others have said lots about that already. So if I run out of time, that's the bit that I'll leave for the breakout room. So here's some results achieved by linking across different healthcare systems. So the government advice at the time was for vulnerable people to avoid air pollution by staying indoors, and they thought this would improve health. And so our question that we asked was, does informing susceptible individuals of episodes of poor air quality enable them to better manage their health condition and result in reduced contact with the healthcare system? So 4 general practices in Port Talbot in the steelworks here in South Wales asked everyone on their vulnerable respiratory or cardiovascular disease lists if they'd like to sign up to receive alerts when the air quality was poor. And 180 people signed up to the intervention group, and 1,200 declined and actually became our control group. And we looked at the changes in healthcare utilisation between these 2 groups. And what we found was not what we expected, according to the government advice. So we found that the people receiving the alert used far more healthcare compared to the control group. And the main result was a 4-fold increase in respiratory related emergency admissions. And I guess this study demonstrated the value of linked data in a real world evaluation. It was a first look, providing useful indicators of increased healthcare utilisation from the worried well, who we think are the ones that signed up, tried to see their GP, couldn't get an appointment, because the system is at capacity. So there were no changes that we saw in the primary care contacts. And then they went to hospital where possibly a junior doctor saw that they were on a vulnerable list and admitted them just in case. So obviously that's our supposition, but we can kind of follow the story across the different healthcare providers, which is really useful. And then for this study, we've linked housing improvements from the local authorities to health data for people in the appropriate social homes at the right time using a type of household data linkage. And so the local authority in question sent the unique property reference numbers for their homes and the month of completion for each type of work, such as heating, kitchens and electrical systems, to NHS Wales Informatics, who are the trusted third party. And then they removed the identifiers and replaced those with a consistently encrypted linking field, a household linking field. And interestingly, they actually told us that the intervention began, I think, in 2009, whereas we saw when we got the data that several interventions or housing improvements had already begun in 2007. So what we found here was the changes in outcomes for the participants living in homes receiving the updates compared to the controls who hadn't received the updates. And so the take-home message was that the intervention was associated with a significant decrease in emergency admissions. And having a bigger data set allows you to segment it into smaller groups to tell a story, because when we looked at only respiratory outcomes, here we've got respiratory, cardiovascular and injuries for the older people, about 7,000 of them in these social housing homes. But when we looked at respiratory outcomes only, we saw an even bigger reduction in the electrical system. So instead of 40%, we had a halving of emergency admissions. We interpreted this as the installation of extractor fans in kitchens and bathrooms as part of the electrical systems, removing damp from homes in one of the wettest regions in the UK, admittedly. So that provides a really useful policy recommendation. And then in the next study, we've just handed in our report to the National Institute of Health Research. So for this work, we've linked individuals into their homes for the correct dates. And again, this has been for about a decade in time. But then we've linked to the relevant exposures in the wider environment further away from home. So that is whether they had access to any parks and ponds or canals or beaches, etc., or any other green-blue spaces. So there was no intervention as such, but this is an observational study. And we use the same residential anonymized linking fields as last time. And we know that the most robust evidence liked by the Department of Health and Social Care, etc., as we've been mentioning today already, with the difference in different studies and that kind of study that allows you to try and move towards understanding causality. It comes from time series data where the exposures to green-blue spaces come before the health outcomes, in this case GP recorded common mental health conditions, anxiety and depression. So we actually stopped at the first recording of a mental health condition, and our study, I think, is one of the only few environment and health studies to have actually achieved this ordering of exposures and events, health events, in such a precise way. So we had rich data at the household level on variations in exposure to green-blue spaces for all 1.7 million people, adults in Wales. And then we looked at the number of times people moved home and took into account the changes in the population over the decade. And having data at such a granular level actually allows us to look for gentrification. So after 10 years, in theory, you could have an entirely different population at the end of the decade. So having that granular data in space and time and linked together through the linkage systems, individual and household, actually allowed us to do that. So briefly, we did find evidence of improved green and blue spaces associated with fewer mental health conditions. for each about a quarter increase in our scale of greenness, we saw a fifth reduction in CMDs, common mental health disorders. I don't know how I'm doing for time, but I suppose I had some thoughts about the differences in the two systems between the SaIL data bank that I've worked in and what's gone on or going on here in the Northwest Coast. And the main differences, I suppose, are that I think we've got this extra component called GraphNet, who are the commercial company. So in Wales, what we had, or what they have there, is the technical staff work over the two systems, the academic and the NHS, and they provide a help with the service provision so that it doesn't provide an unnecessary burden on the health services. So there's a lot of infrastructure investment going in that way. And here, I guess, what we're doing at the moment is that research staff have the sort of two hats. They have academic hats and they have the NHS contract as well to allow them to access data. And then we've got this an extra layer, if you like, of GraphNet. So I suppose in some ways we've got to be even more clear about our processes, because there's this extra step in the middle. I'm sure we can do it, but it's just that extra layer in the middle. So we've got to make sure we've got transparency between all the partners, which is challenging anyway, but definitely possible. I guess I'd just like to finish by saying that I'm invested professionally in making sure that data linkage systems work in our region and for other regions across the UK. I think that everyone having access to health promoting facilities in the wider environment as well as the health services, is important for people's health. So and the extra driver for that is the funding we've been awarded with Ruth and myself and Ben Barr and others, and the importance of the Mersey Care and the CIFA and Helen and Wes in driving this forward. So hopefully we can actually expand the data linkage to include the environments and the interventions that we will drive forward as part of Groundswell, as part of this the regeneration of our cities post-COVID. So I think I'm going to end there and pass on to the next speaker, or answer questions if I've got time.
Thanks, Sarah. Unfortunately, I don't think we have got time for questions, but I'm sure people can email them to you. Yeah, I mean, it was a fascinating presentation, which is why I didn't want to stop it. But we probably should now move on to Pete, who's going to talk about using routinely collected health data to assess the effect of a seizure care pathway. So pass over to you, Pete.
Thanks, John. So yeah, good afternoon, everyone. As John said, my name's Pete Dixon. I'm a researcher at our Northwest Coast. I'm going to be talking to you about using routinely collected health data to assess the effect of a seizure care pathway. So just a bit of background for you. Seizures account for around 1.5% of all adult emergency admissions. In terms of volume, there's also a similar number of people who attend, they present and are discharged without being admitted. It's not like other conditions like, say, for instance, COPD, where you expect someone's declining health status to necessitate repeated visits to A&E. The majority of people with seizures can be well managed. So when they do pitch up at A&E, it's a great opportunity to intervene and deliver better care. Now, we know that there's a lot of issues with care for emergency presentation of seizures through the National Audit of Seizure Management in Hospitals, or NASH, which we've led on from Liverpool for the past decade or so. There's a lot of aspects of suboptimal, but specifically in relation to this talk, referral rates are very poor. National clinical guidelines say that someone who shows up with their first suspected seizure should be seen by a neurologist within 2 weeks. Our second round of the audit showed that this group of people, less than half of them were getting referred at all, and the average wait time was well in excess of 2 weeks. Our local strategic clinical network got wind of this, looked at the results, and thought that referral rates could be easily improved. That was the theory, at least. So they could be improved in a local area. They got together a group of stakeholders, clinicians and patient charities and came up with the Walton seizure pathway that was rolled out across the region in 2015, and it was to be used for all emergency seizure presentations. In brief, what the pathway is, it's a paper-based pro forma. On the left, there's things to guide the clinicians, how to manage the patients, how to treat them. On the right, there's something for the patients to take home around seizure management and first aid. There is a form that is then faxed by the medical team to the Walton Centre. Now, the Walton Centre is the specialist neurology trust that covers Cheshire and Merseyside. An expert consultant there will triage that presentation and say whether or not they should be offered a referral. Now, this is all well and good in theory, but the experience of clinicians involved in the project was, would the pathway be followed? Their experience from other pathways is it gets used for 2 months, forgotten about, and gets buried under the myriad other pathways for other conditions. Yeah. So as I said, the Walton Centre provides neurology services to 7 trusts in the region using a so-called hub and spoke model. Around the same time the seizure pathway was being launched, the forerunner to ARC, the Clark Northwest Coast, was being launched. And one of those projects was the Care After Presenting with Seizures, or CAPS project. Nurses were employed at 3 of the hospitals. They're shown in red on the map of God's Own County on the right. So it's Arrow Park on the Wirral, Aintree in the middle, and Warrington on the left. And for those of you who are unfamiliar with the region, poor you, A, but B, the Walton Centre pretty much occupies the same footprint as Aintree Hospital. Those nurses were tasked with identifying admissions suitable to be put on the pathway, chasing those up, facilitating referrals, educating the ED staff. And we wanted to know what is the effect of the pathway and of the CAPS nurse enhanced pathway on referral rates. So to do that, we use routinely collected hospital data, secondary use of services data, or SUS, held by our local commissioning support unit. So that's data on all the A&E, all the admissions and all the outpatients across all the hospitals in the region for all conditions. So we needed to define our cohort from the admissions and then look to see, follow them through using their unique identifier number to see whether they attended or whether offered a neurology appointment within a certain period of time. So how we define the cohort briefly, the SUS data has up to 23 diagnosis positions for emergency admissions, where there's a code relating to what was the reason for the admission. Commonly used algorithms such as NHS Right Care or the Getting It Right First Time team only use the primary diagnosis field. They have a small number of epilepsy or other seizure related codes, but we think a better way is to use a mixture of primary and subsequent diagnosis positions. So for instance, imagine someone has a seizure, falls, trips, hits their head on the ground and fractures their skull. When they go into hospital and are admitted, their primary diagnosis will be skull fracture and a secondary diagnosis of seizure. But actually the seizure is the underlying reason for them being admitted, because that's why they fell and injured their head. But and they wouldn't be picked up by Right Care or the GERFT algorithm. Another situation, say someone comes in with a myocardial infarction primary diagnosis and an epilepsy secondary diagnosis, that is basically a heart attack in someone who happens to be a patient with epilepsy. So it's not a seizure related admission. We believe our algorithm is better, and we've got a paper in progress that does so that it outperforms both of those above algorithms in terms of increased sensitivity and specificity. So if we just go back, we've got 8 years worth of data, which covered over 10,000 admissions. If you look at that middle section, the admissions, because we know where and when the admission took place, we know whether that was before the pathway was in existence, whether it was during the pathway's use, whether it was one of the sites who had the pathway and the CAPS nurse trying to help out, and then also whether it was post those CAPS nurses, when their funding ran out, because we thought they may leave an institutional memory into the hospital. We then looked at whether these people got to see were offered an outpatient clinic within 3 months. That was chosen as a reasonable balance between giving the hospital enough time to get the appointment sorted, but it wasn't so long that the patient thought, oh my God, how long is this appointment going to take? We also split it as to whether patients had been seen in a neuro clinic, in the 12 months prior to their admission, because we knew from previous work, those already under care of neurology are much more likely to be referred on following an emergency admission. So just briefly looking at the results are the main focus of this talk, but you can see there, Group A are those people already under neuro consultants, and Group B, which is a mixture of first suspected seizure and patients with known epilepsy who are being lost to follow-up, are on the right. And you can see there is a big difference in the amount of people getting an appointment, an outpatient appointment. You can also see that there is an increased slight in Group A when the pathway is being used, a bit bigger, and with a bigger again with the pathway plus the nurse for Group B. A more sophisticated logistic regression showed that the only positive statistically significant impact was the pathway plus the nurse or post-CAPS nurse for those people who were not under neuro review. We also showed that there was institutional ageism. This is known quite widely in seizures and epilepsy, that the elderly are much less likely to be referred. It's a national scandal, in my opinion, but it's important to note that the pathway didn't make this any worse. It was in operation before, and it persisted. Also, people from the most deprived quintile, who made up around 50% of these admissions, they were less likely to be referred as well. As I say, I don't want to, the results are a little bit disappointing, that we didn't see the impact that we wanted, but the thrust of today's presentation is to show that it is possible to do this type of thing. So we showed it was possible to use the data and assess the performance. The algorithm that we've come up with has been recommended for use at a national level by the National Neurology Advisory Group. And the Getting It Right First Time team also now use the 3-month referral rate as a key metric to assess hospitals' performances. But things that we would have liked to do and we can't do either because we didn't have the data at the time, or the data, there's issues with the data that Peter referred to actually in his question to Joe earlier. We were only able to look at admissions, so admitted patients. The A&E data is so poorly coded, we have no degree of confidence that someone comes in as a result of a seizure. So that's pretty much half the patients who we were, half the interactions with ED we weren't able to look at. There's no coding of diagnosis in outpatients data sets routinely. So Joe mentioned in Herzog, Hedley Elmsley, who's based up at Lancaster and Royal Preston Hospital. He is messianic about this, improving the diagnosis and coding in outpatient data sets. We had to assume that an outpatient referral was made as a result of the admission, but it might not have been. It might have been a pre-existing one for a completely different condition, but there's no way of capturing that and digging down into the data. Also, and this is quite a big one, is that the Walton Centre operates something called a partial booking system, which means they write to the patients and say, we can offer you an appointment, would you like one? And only when the patient writes back and say yes, does that appointment then appear on the SUS data. This is done to improve DNA rates, but actually I think massively important, I think, because certain groups of the population are much more likely to respond positively to that to that invite. There's research that shows that women are more likely to respond positively than men. People who are better off are more able to take time off to go to appointments, but we can't actually dig down and look at that data. Also, where the outpatient appointment took place, we couldn't tell. And the beauty of using the neurology in the hub and spoke model is it's very well coded because there's payments going to the Walton Centre for these clinics. The downside is they're all coded as a Walton Centre clinic, irrespective of whether it takes physically at the Walton Centre or one of the satellite clinics. And this is a group of people who have issues with driving because of epilepsy and seizures. If you're based in South Wirral and need to get to the Walton Centre by public transport, it's a nightmare. If you need to do it from Southport, it's a nightmare. So we couldn't look at that. We have no link to GP data. If we were running this now with the Cypher database and going through that, that would be great because they have coding of whether these are patients with epilepsy or not. And so we'd be able to stratify the population more. And having all this information, so adding in the information to what we already had, would enable us to do more nuanced analysis and also look at potentially interventions that are based in geographies or for specific groups of people. We had a rather clunky way of getting data, by which I mean there was someone at the CSU, who the Commissioning Support Unit, who was seconded to us, who was doing things slightly one step removed. And there was also a lack of persistence. The academic who was leading this and the person at the CSU were doing quarterly reports as a carrot and stick approach to the hospitals to say how they were performing, try and use them to improve their performance. The academic retired, the person at CSU got working 8 days a week on COVID, so there's a lack of persistence. But in summary, we managed to show it can be done, but I think there's much other ways. If we can add more data and more richness, we can do it better. So thank you for listening, and I'd just like to acknowledge the other people who were involved in the project.
Thanks very much, Pete. That was a great example of applying these approaches to real life patient problems and some of the challenges involving that. There were some questions for you in the chat. I don't think we've got time to ask them now, but maybe if you've got time to answer them, or people
Sure.
can email you separately. Thanks a lot.
Yes,
so we'll move on to our final presentation before breakout rooms. And it's great to welcome Ollie Butters. Ollie and I used to work together in Bristol many years ago. He shares my enthusiasm for Scottish whisky, amongst other things. Well, he used to do. So Ollie's going to talk about using routine data to generate an index of anticholinergic medication burden on older people. Thanks, Ollie.
Thanks, John. So hopefully you can see my presentation, shout if not. Yeah, so my title is about using routine data to generate an index of anticholinergic medication burden on older people, which is a very long title, so we just call it ACME, so that's much easier to refer to. So first up, anticholinergics. So that's quite a broad class of drugs. They, as a class, what they do is they block a particular neurotransmitter. And there's quite a lot of them on this slide that goes off the edge. There's over 100. There's probably a bit more than that. So there's lots of things, or lots of anticholinergics, and they do lots of things. So they're used to treat things like COPD, asthma, dizziness, bladder, bowel, mood problems, and some other things as well. So it's quite a broad use of medications. There's quite a lot of side, or there can be quite a lot of side effects with the anticholinergics, particularly for older people. And that can include confusion and falls, and those often lead to admissions to hospital. What's worse in the older population is that they're more likely to have multiple long-term conditions, and so they're then more likely to be taking multiple anticholinergics. And so then we've got the risk of an additive effect, as well as potential interactions between the different anticholinergic drugs. On top of that, so it gets worse, there are a group of older people that do tend to have, or do tend to be a bit more sensitive to the adverse side effects of anticholinergics than other people. So we've got this sort of situation where, particularly in the older population, there's groups that are taking lots of these drugs. Might not be too good in combination for them, and it might have a bad effect, or a particularly bad effect on some of that group. And so the aim of our project, this ACME project, is to develop an index. Maybe it's an index, maybe it's not an index, maybe it's a score, maybe it's an indicator, maybe it's a risk. Different groups assign different meanings to words like index. So I'll stick with index for now, but you might disagree that it's strictly an index. So the aim is to develop an index that tells us the risk that anticholinergics have on admission to hospital with confusion or falls, and we're doing that in the connected Bradford data. And the idea is, when we've developed this index, we'll run the model, we'll run this index in some GP surgeries to find some patients that are at highest risk, and then we'll look at what we can do to help deprescribe those patients. And then eventually that data from those GPs will flow back into the connected Bradford system, and we'll be able to look at a sort of population level whether the intervention that we're doing is having an effect or not. And then, as well as doing all of that, it's a big project, we're looking to validate our work in some other regions, because the data in Bradford, it's very specific to that population. Maybe it's a little bit different elsewhere, so we're going to run it in Sale, so looking at Wales, and also up here in the Northwest. And quite what that population looks like, we're still working through. So that's the aim. So the data, connected Bradford data. So connected Bradford has data on primary care data on 868,000 patients. So that's all the GP data, things like appointments, medications, clinical history, and this sort of stuff. And that's based on 86 GP practices across Bradford and Airedale. Linked to that is the secondary care data for the region as well. So, things like inpatients, outpatients, pharmacy, this sort of stuff. And so that's all linked together, and it's been pseudonymized. And then that's made available in the Connected Bradford platform, which is a really nice platform to use. I really enjoy using it. It's you can log into it. It's basically a web-based interface. You can log into an RStudio web-based instance to do your analysis, and you can also connect directly to the database to poke around in it and see what's in it. So in terms of user experience and the data, Connected Bradford is really good. I would recommend having a look at it if you haven't in the past. I couldn't mention the data without talking about the underlying data model. So Connected Bradford have gone through a lot of work to push through, or to basically transform their data into the Odyssey OMOP common data model. So this is a common data model. So a common data model is a sort of like a database design. You know, it specifies the names of tables and what columns should be in the tables and how those tables should link to other tables. And the idea of having this common data model is that we can write our analysis scripts around this data structure, and then in theory, we can pick up our analysis scripts and run them somewhere else where they formatted their data in their common data model, and it should just work. And that would save so much time, so much effort. This sort of relates to, I think, one of the questions that was asked of Ben earlier on about what we can do to make this a bit easier to share and reuse code. So this is one of those things. If you're building data models or thinking about linking big systems together or whatever, please have a look at stuff like OMOP. If that's the one thing you take away from my talk, I'm very happy about that. So in terms of the model that we've built, so we've got our model. It looks something a bit like the thing at the top. It includes things like age, frailty, how many anticholinergic drugs people are taking, that sort of thing. And it gives us the probability of a patient getting coded for a fall or delirium in the next 30 days, given that they haven't been coded with a fall or delirium within the recent or the last 12 months. So that's sort of the thing that we've managed to develop with the connected Bradford data. And then what we've done is we're working with 8 GPs, what we're currently doing. So we're working with 8 GPs who all use System 1, and we've built a report within System 1 that extracts the relevant data that we need. So things like some of their conditions, which drugs they're on, that sort of thing. And then we pass that data, so we sort of process that data with another Excel file that's got a VBA script in it. And you know, VBA scripts in Excel aren't great, and those of you that know me might be surprised that I've said those words. But you know, we've got to do something to get it to run on GP systems. So that's the way we've had to do it. And it generates an output like this, like the screenshot. And so it gives a sort of all the various risks based on, you know, how many anticholinergic drugs they're taking, as well as a risk based on that and conditions that they've got. And the idea is that a GP or perhaps a pharmacist could then look at this output, perhaps sort it by highest risk or highest absolute risk or something, and then figure out what we're going to do. And then, so there's a work stream going on with that at the minute to figure out, should we just start at the top and work down, or should we start in the middle and try and stop people moving up the list? But you know, that's really just sort of kicking off at the minute. And then, like I said, we're going to run it in Sale, and we're looking at doing it in the Northwest. And it's got mentioned in System P work. That may well be the frailty and dementia work that goes on. And with that, my last slide with everyone that's on the team, and I'm done. So that's a very quick whiz through of what we're doing.
Thanks, Ollie. That was great. You were so quick, and you've only run over time because you started late. I mean, does anybody have any questions for Ollie before we move to the breakout session? I'll quickly ask. I mean, given that this is System 1 based, I mean, could you run this in Open Safely as a national thing?
Well, you know, System 1 isn't entirely national, is it? There's different places have different things.
But it's what, 24 million people?
Yeah, it's a few. Yeah, I mean, you could potentially do something with with Open Safely. I mean, I haven't used Open Safely, so I don't know how well that would translate. No. So I don't really have a proper answer for that.
No, that's fine. No. Any other quick questions? I can't see any hands up, and I can't see anything apart from, yeah, general comment about some of the content's been a bit complex. So Sarah's going to organise another session specifically for public contributors, which sounds great. So I guess we should move to the breakout sessions. so see you. We'll see some of you in the breakout sessions, and then see all of you afterwards.
Yeah. So I guess just quickly to introduce the breakout rooms. So the object is to have the discussion about the silos, and we've started that already about data linkage and trust and other topics like that in the theme for the day. So we've got a couple of facilitators, Joanne and Victoria, helping us with these with the discussions, and then Pete and Ollie are going to take notes for you, but there's a couple of links where you can actually write in the an idea board yourself if you wish. So the idea is not to have that idea board though showing, so that we can actually see each other. So if you want to click on that link separately and have it open, if you're lucky enough to have two screens like me on your other screen, that would be great. But not to worry if you can't see that, because as I said, we'll have facilitation, and we can share the results of those boards afterwards as well. And Ollie and Pete are going to be actually typing into there, so you can just talk and be assured that that will be captured, so that's fine. So I guess just wanted to share, I'm going to share my screen with you briefly, because I've got something from my system work that I've been introduced to. And so as well as Ollie's OMOP model, you might actually remember the pig model from today, which is a way of just saying really that we're thinking about the data bank and creating this data bank to improve population health. And people have got different priorities and perspectives on this, and so every view is definitely correct, and whatever you have, some people's views might differ, but you can look at having the data bank instead of the pig in the middle of this model, and thinking about how we might all have slightly different perspectives, and how we can align those to make sure that we can hopefully improve population health. So I'll stop sharing now and ask if there's anything I've forgotten, and if not, maybe we can move into breakout rooms.
On that note, so I think now we've got feedback from the people who were collecting feedback in the two in the two breakout groups, and then we've got some discussion of the feedback, and I think we've got till about 5 to 4, and then Sarah's going to summarise things. So I'm not sure who's first to give feedback from the discussion groups. I know it was, I think Pete was making notes in ours.
Yeah, I'll go first if you want. So I'm just squinting because I was writing it on a different computer. My eyes are off. It's age. It's a horrible thing. So there was something about basically what does success look like? We said that it's different for different groups. So having the data is success for the researcher, as a lot of us know. But actually, for the citizen, it's making a positive change and improving health outcomes. So there's different people. Success means different things to different people. So Peter Lloyd mentioned sort of making a real, measurable, and useful difference in the world, and also about the fact that inclusivity is needed. We need to use the data to lock into the population as well as the health service. It needs to be sustainable. There was an interesting discussion around sort of patients about don't always assume that people are uncomfortable around the confidential data being shared, as long as it's treated with respect, etc. The IG processes have done. And Gary mentioned the fact we need to recognise there are challenges around confidentiality, but we need to work with the patient groups to overcome them. Also, be clear that to the public and others who aren't so academics, that research doesn't always come up with a clear answer. And that's not because it's bad research, but that's just the nature of research. So we need to be honest with the public about what research is and what it can do. And there was also allied to that, sort of removing a false dichotomy between what academic research is, and BI and service evaluation, so business intelligence and service evaluation. It's all basically aimed for the same thing, which is improving population health, but often there's a sort of false dichotomy between it. And then what's essential to achieve success? Let's have a look at this. So patients need to feel empowered, and how much are the people affected by the research helping to drive the narrative and contribute the data? Be conscious of potential bias in the analytics, which is something that we've mentioned at one of our previous ARC-fests. And allied to this, we're talking about sort of routine data isn't always routine for certain population groups and certain stigmatized conditions and stigmatized groups where that data isn't always collected, or it might be collected differently in different data sets. We were also talking about linkage to non-health data sets, such as police data. And interestingly, John was mentioning that actually with a project that he's been involved with, people are actually more comfortable with their criminal records being linked to than they are with, say, their economic records or their health records, which did come as a surprise, I think, to some of us. Always data that's always up to date. So, you know, rather than cross-sectional data, we need the data to be up to date so we can do these sort of, you know, analyses over time. And yeah, also collecting data on social determinants of health. So that's again linking to these other non-health data sets. And then we mentioned that the quality of the data isn't always there, such as ethnicity, which Jenny mentioned. Although Helen did point out that it's there in some of the data sets. It is good in some data sets and not in others. So if we can work out good methods of linking the data, we can overcome some of those issues. And I think, unless anyone else from my group's got anything they'd like to add, I shall pass over to Ollie for his thoughts.
Thanks, Pete. I think that was a really comprehensive and summary, and I don't think you missed anything important from my memory of the session. So I mean, so if nobody else from our group's got anything else that they want to add, then move over to Ollie.
Thanks, John. Yeah, so I think reassuring that there's quite a bit of overlap between the two groups. You know, it's good to know we're at least on the same page, at least partly, so that's good. Yeah, so we spoke quite a bit about improving patient care and how that's got to be an important part of whatever we do. When it comes to sort of building some sort of system, be it sort of a data bank or whatever, you know, it having access or data being able to be put in it from a wide variety of stuff, so, you know, not just healthcare data, all of that education and environment and whatnot needs to go in it. And we did speak quite a bit about that in terms of you know, being able to find out who's benefiting from the work. So, I mean, Sarah's example, her talk earlier, you know, the council paid for work to be done on houses, and that benefited the NHS in terms of less people going into hospital. So that sort of global picture of what's going on needs to be there, so we can see who's doing the work and who's benefiting stuff. Yeah, very, very person focused. Bringing everyone together was another success that I quite liked. You know, it's one thing saying let's build these systems, but to bring all of the relevant people in the region or whatever together so that we're working towards a common goal, that's really important. In terms of what we need to do to achieve success, buy-in from the top, massively important. I think we all agreed with that. An understanding on what people's agendas are. You know, different people from different groups will have different agendas that they're trying to achieve. You know, different organisations and whatnot. They may want a common goal, but what they get out of it and how they get there might be different. Consent came up, and how, you know, when we're talking about big linkage systems, how it's even more important that we understand consent and make sure that is adhered to and followed through the systems. It's so easy to lose that when you're moving data out to different organizations and whatnot. Somebody's put, we've got to have an ethical data model. I really like that phrase. I don't think we've got to discuss that in our bit, but that's a lovely phrase. So I think I'll end there on my summary, and then if there's anyone else in the group that wants to mention anything that I've forgotten, please do. Oh, there we go. Sounds good then.
Thanks, Ollie. That's great. We've got 5 minutes or so if we want to use them for general discussion. I don't know if anybody's got any general points they want to make, either points based on things that were spoken about in the breakout rooms, or things related to the earlier presentations.
Vicky's got her hand up.
Yeah, I think it was just related to the last comment we made in our breakout room about consent and informed consent for patients. And I was just thinking that if it's anonymised and you consent to your data being used and you can't be identified, does that still raise issues for patients giving consent? Does it make people feel uncomfortable still when they cannot be identified at all? I was just wondering what people thought about that.
Yeah, I mean, good question. I mean, you know, in terms of legally, if it's truly anonymised, you don't need consent. The debate's usually about what's truly anonymised, because as long as uniqueness is apparent in data, you know, somebody who knows a combination of characteristics that identify you can identify you, even if, you know, it's not got your name or your NHS ID or anything like that. But a number of people have got their hands up, so Helen, then Mark.
I think that it's sort of playing to the point that you were making, in that where it's patient level but not identifiable, I still think, I don't know if it's the exact legal basis, but I still think we've got a duty to explain to patients and to people that that data is being used. I think it becomes a problem when we don't feel like we've informed them. And I do think, honestly, I do think there's probably swathes of the population that don't realise, for example, that me as someone who administers the healthcare system might be able to see that patient level data, if in all honesty. I think providers try to tell people how we use their data, but you know, how many people go and read the notice and really understand? So I wonder that the people who haven't gone into the practices or to the healthcare providers to say, I don't use my data, though, for the people who haven't done that, they're probably a bit agnostic to this issue and maybe wouldn't be that bothered, but do we really know that? And so I think it's about being informed. Yeah.
At the moment, oh yeah, sorry, I was just going to say, because at the moment you kind of tick the box, do you wish your data to be consented for other things, but actually there's no details on it, is there? Sorry.
No, I think thanks. I think that's completely true. Mark, you've got your hand up.
Yeah, thanks. Just thinking about the data set itself and how it's going to be, you know, managed going forward. Is it a kind of agreed or, you know, sort of accepted point that there is going to be a central core set of data, but also then systems at the touch points of where people interact with that data, that they will have their own sort of data set, and then just the shared bits will be updated? Or is it are we looking to move that we have a complete control of the whole data?
Thanks, Mark. Would someone from the Cheshire and Mersey team like to speak to that in terms of your data?
Sorry, do you mind just asking that again? Sorry, I heard half of it.
It's about having a core central population level data set, and then having some data that are only available to certain people, I think. And I was just going to come back with what happened in the SaIL data bank, in that there are in the SaIL data bank certain data sets that are core to process. So there's the demographics data, the normal names, de-identified person level linkage, and so we've got age and things like that of the person. And then you've got hospital episode statistics, when they've gone into hospital, and the GP data are all core. But then there's certain data sets, such as the housing data set that I brought in and linked as part of a project, that are sort of peripheral to that and aren't regularly updated. So there's that kind of issue as well. So in the core data sets, they're all there and updated. And there might be certain specific data sets that a researcher or you know, for a certain project that have been accessed and need sort of to be treated slightly differently, perhaps. So that was my take on it.
Yeah, I guess it's the concept of sealed envelopes that some people talk about in this context. Helen, did you put your hand up again, or is that a legacy?
Yeah, sorry, it's going up and down. I'm not very good at Zoom. I'm normally on Teams. So I suppose just for the Cheshire and Mersey context, when we roll out the sharing agreement for the trusted researcher environment, there won't be a set of core data sets that will automatically be available. Any one research project will have to justify the purpose and the requirements of each request. So that might be, well, I need these 6 fields from this, you know, secondary care data set, and I need to know that it's just the people with learning disabilities from the primary care data set. And we will be like subsetting the data, all pseudonymized, but still minimizing access to just the specific research purpose, which I think is an extra layer of governance, just to sort of protect against, you know, that possibility of sharing too much data for potentially reasons that you wouldn't need to.
Yeah, thanks, Helen. I was just struck again by another important point, that it was something you said earlier reminded me of it. I mean, this question of what's legal and what's not legal. I mean, I think it's worth remembering that just because something's legal in the strict legal sense doesn't mean that people will think it's okay. You know, and it's this concept of social license, which is, you know, where the whole care.data thing fell down.
Well, and so I mean, just to come back on that, because I do feel quite strongly about this, because when we started to implement Cypher, we had a lot of this. Well, it's legal because we've got COPI, which is the COVID, you know, which and we can just take it. We can just take the data. And I made exactly that point. I said, just because it's legal doesn't mean it's right or in the spirit of data sharing. And we're still in that space sometimes where we get people to say, well, we've got the sharing agreement now, so we can just do this. And we actually have to say, yeah, whilst you've still got your GDPR clauses that are fine and you've satisfied the common law duty confidentiality, actually, is that in the spirit of the data sharing agreement that we've got with the public and with our data controllers? And so I do think that, like, for me, that's massive. And that is how you gain the trust, because you're not just going all in to get the data and do whatever it is that you think you need to do without considering people's views and opinions on that.
Yeah, I completely agree. I think that is a massive point, and maybe it's an appropriate one to end on, because we're coming to the end. It's now, we got 4 minutes left. Did anybody have anything else that they wanted to raise before we move to Sarah's summing up? I mean, I think this has been a fantastic afternoon. I mean, I've found it incredibly stimulating and informative and a really great use of my time, which I can't often say about Zoom meetings. Okay, if nobody's, I can't see anybody else with their hand up. So Sarah, I'll pass back to you.